Thank you for the introduction. And I would like to thank the organizers for having me here for speaking about staging renal cancer. So, if a physician encounters a solid renal mass, in 80–90% it's going to be renal cell cancer. The next talk is about the other 10 to 20%, how you can identify them and spare them from surgery. The other ones would have to be treated because RCC has got the highest mortality of genitourinary tumors. Usually the patients are male, older than 50 years old, usually sporadic, but there might also be a genetic fixation like von Hippel-Lindau or tuberous sclerosis. And the long time classical presentation has been hematuria. But nowadays, because this is usually an advanced RCC, we don't see this anymore because most of the RCCs are discovered incidentally. So the primary workup of RCC is of growing interest because we have changing therapy paradigms. We now have nephron-sparing surgery, tyrosine kinase inhibitors, mTOR inhibitors. So we want to monitor post-operative changes. And we also want to monitor treatment. And because the treatment has changed over the last 10 years, we also have to know about new side effects. So the learning objectives of my talk are to discuss the optimal imaging protocol for diagnosis and staging of renal cell cancer. And I would like to present typical findings, representative for the tumor stage. And then I want to talk about treatment options and their implications. So first, I want to talk about the modalities and protocols. And most commonly, RCC will be discovered on ultrasound. So usually you will find a solid or cystic mass, hypo to hyperechogenic, just depending on their size. The bigger they get, there might be also necrosis. They may also contain calcification. Typically, you will get a Doppler signal in those vascularized lesions. If there's lots of necrosis, then the Doppler signal might be reduced. However, ultrasound, as everybody knows, is truly operator dependent, and just dependent on your experience, you also may miss tumors. Accuracy for local staging of ultrasound is 50 to 70%, depending on the literature. Especially evaluation of retroperitoneal tumor spread can be difficult. But evaluation of the kidneys, the livers, and also the regional lymph nodes is good, so they may be evaluated. And ultrasound has also got a role in diagnosis of thrombi in the renal vein or in the inferior vena cava. Those usually show diffuse echo and a missing Doppler signal. Contrast-enhanced ultrasound may also improve the detection and characterization of tumors and also tumor spread. And a recent development has also been image fusion, where we can better detect tumors. For example, we can fuse a CT data set with ultrasound and better locate those tumors. And this might be helpful to diagnose unequivocal findings on CT, which brings us on CT. So we want to do differential diagnosis. We can do a very elaborate CT protocol. We've got the unenhanced phase, the corticomedullary phase after 20 to 30 seconds, nephrographic phase after 1 minute to 100 seconds, and delayed phase after a couple of minutes. So this is good for distinguishing between hemorrhagic cysts and tumors. But if you want to do truly just staging to stage the tumor spread, the nephrographic phase, venous phase enhancement is enough. If you want to, why do we just need the nephrographic phase? The contrast between tumor and kidney is highest in this phase. Independent if you got clear cell carcinoma or papillary carcinoma, clear cell carcinoma usually show hypervascularization in the corticomedullary phase, whereas papillary tumors are hypovascular in the early phases. But we can nicely distinguish them in the nephrographic phase. If you want to distinguish between enhancing tumor regions and unenhancing tumor regions, dual energy might also be worthwhile because you can save radiation, because you can calculate a virtual unenhanced image. And this reduces the dose of your examination of a virtual dual phase CT against a truly dual CT by 50%. Dual energy might also be nice for evaluating polycystic kidneys, where you can identify the contrast-enhancing cysts. Diagnostic accuracy of CT is very well, especially for capsular infiltration, venous thrombosis. Literature is not sure about the accuracy for nodal disease because there might be micrometastasis in small lymph nodes, so you cannot really diagnose them on CT, on plain CT. The diagnostic accuracy is very good for distant metastasis, and it's also quite good for the correct grouping, stage grouping. So that CT, whole body CT, is the mainstay if you want to diagnose, if you want to stage RCC. So typically we would acquire a thorax and abdomen in a delayed venous phase. So this is we will talk about this case later. The role of MR, so typical MR protocol would be in phase or post phase to detect fat, microscopic fat in tumors, for example, like in angiomyolipoma. T2 weighted sequences, T1 fat set before contrast application. You can shorten your protocol if you acquire a Dixon sequence with new acceleration scheme, like Caipirinha Dixon. You can do one breath out, you get a post-phase, in-phase, a fat-only image, and also a water-only image, which is also a nice fat-saturated T1 sequence, so you can shorten your protocol. You would also acquire a nephrographic phase after contrast administration. The question is, do you need an arterial vibe phase, or you might also do arterial phase, for example, MRA, if you want to evaluate the number of renal arteries, which is important if you want to clarify if a patient can undergo partial nephrectomy. And you can also, in a delayed MRA, you can also evaluate the renal veins. Diagnostic accuracy of MR is similar to CT. It's non-inferior. Might be, if you have got a patient with unequivocal finding in CT or ultrasound, MR might be the way to go. And MR is, I think, also good for patients with renal insufficiency, patients that already underwent radical nephrectomy. Here, unenhanced MR might be good, or is good. And regarding lymph node staging, there might be a role for iron oxide particles. I will talk about later. And MR also allows for functional imaging like DCE MRI, where we can quantify perfusion and permeability of tumors. And we can also do diffusion-weighted imaging to assess the cellularity of tumors. So with these weapons, this armament, we want to go and stage our tumors. And first, I want to talk about staging system. So the sense of a staging system is to predict survival of a patient. So stage 1, stage 2, this is limited to the kidney, excellent 5 years survival. If there's local infiltration, sinus fat or perinephric fat, survival goes down to like 50 to 60% after 5 years. And if you got advanced renal cell carcinoma, if you got tumor that is invading beyond the Gerota's fascia or is directly infiltrating the adrenal gland, then the 5 years survival goes down to 0 to 20%. So this image is already quite old. And because nowadays adrenal gland is stage 4, a couple of years ago it still has been stage 3, but direct invasion of adrenal gland limits your survival. So T1 would be the classical small RCC. So small RCC is smaller than 7 centimeters. There's also subgrouping. T1A is more than 4 centimeters. So the classical small RCC, and we'll talk about the treatment later. T2 is the large RCC, which still sticks to the kidney, does not infiltrate the surrounding tissue, not infiltrate the sinus fat. If it's bigger than 10 centimeters, it's T2B. The others between 7 and 10 are T2A. T3 is the local infiltrating tumor. So local infiltration is if the tumor spreads into the perirenal fat. So so we can see here stranding of the perirenal fat, also some nodular components. And sometimes it's not so easy to distinguish just between reactive changes. So this is usually more linear stranding. If there's some nodular component, you might imagine here, there's more likely to be perirenal infiltration. But however, even linear infiltration might also be infiltration of the perirenal fat, but usually we tend to overstage the infiltration. Also important is the infiltration of the sinus fat, because this also limits the survival rate. T3A is also infiltration of the renal vein, or the branches of the renal vein In ultrasound, we usually don't get Doppler signal from the renal vein, and we can see soft tissue mass extending along the renal vein. But still, the tumor is limited to the carotis fascia. And also, this is also T3A, is a tumor which grows along the renal veins, not in the vena cava yet, and we here have infiltration of the perirenal fat and also of the sinus fat. T3B and C is tumor which grows into the inferior vena cava. If the tumor is above the diaphragm or does infiltrate the wall of the vena cava, it's T3C. So ultrasound might be quite good to distinguish, to show the tumor, and it's also quite practical to show if this is truly tumor or just tumor thrombus. Here we can say this mass from the right renal vein in the inferior vena cava. If we administer microbubbles, we can nicely see enhancement of this soft tissue mass just before the vessel itself shows enhancement. And if we look at the late phase, we can see that there's already washout of the microbubbles, while there is still contrast agent in the vessel. So these images were provided by my colleague Dirk Klevert. So this is T3C tumor, atrial thrombus. We can also see the tumor in the vena cava. We can see tumor here in the right atrium, and this is a MR senior sequence where you can also see that the tumor thrombus is not adherent to the wall. And this is a similar case also with atrial thrombus, which also protrudes into the right ventricle during the systole. This is a very interesting case. Would like to show it as a horseshoe kidney with a giant tumor and vena cava infiltration. There's a horrible tumor. Interestingly, this tumor could even be resected. In histology, the pathologist said it was R0 resected. And T4 finally is locally advanced RCC, as I said, direct invasion of the adrenal gland and infiltration beyond carotis fascia. Here we have beginning infiltration of the psoas muscle and the small bowel, and this tumor is not operable and has, of course, a bad prognosis. In this tumor, we can also see that there's also lymph node spread. We can see a large lymph nodes in interaortocaval, and which brings us to the end staging. You can see the significance of lymph nodes. If you see here, if the patient is positive for lymph nodes, survival rapidly goes down. And the question is, what are the regional lymph nodes? The regional lymph nodes are the lymph nodes around the renal vein, and the para-aortic interaortocaval lymph nodes and the paracaval lymph nodes. All other lymph nodes are distant lymph nodes. And this is this is advanced disease. One lymph node would be still stage 3. Usually, lymph nodes if they're enlarged, can be detected with CT or MR. Problem, as I said, are micrometastasis. There might be a role for diffusion because it also can show infiltration of small tumors. There might also be a role for small particles of iron oxide. There's just one work regarding this topic. This has shown that tumors which show RCC infiltration do not take up this iron oxide particles because the tumor lymph node macrophages are replaced. So one word regarding tumor histology. Papillary RCC has typically a better prognosis compared to clear cell RCC, better survival. There are, however, certain subtypes. There's RCC type 2. These tumors usually look little bit different. They tend to be larger, and they have irregular margins, and they have a bad prognosis and tend to recur. So if you got a patient who has papillary RCC type 2, you would rather do a rather closer follow-up. Also, there might be hereditary multiple papillary RCC. So if you got papillary RCC, you should closely look at the kidney because there might be a second tumor or in the same kidney or contralateral tumor as well. And if papillary tumor metastasize, then this is usually a bad case because the survival of papillary RCC with metastasis is worse than with the clear cell variant, as we can see here in this patient with in a 3-month control. And the problem is that anti-angiogenic therapy usually doesn't work. So this image brings us to M, metastasis. Common sites of RCC metastasis are the lung, bone, lymph node, liver. Brain is not so often, about 8%, so that a brain scan is usually not regularly acquired. Typical localization of metastasis are shown here. As I said, lung, lymph node, bone. Here's some brain metastasis. Metastasis of RCC are usually hypervascular. But RCC is one of the tumors who tend to go everywhere. So if they start spreading, you should really closely look everywhere. So this is a patient with RCC metastasis in the parotid gland, metastasis in the hypopharynx. Muscular metastases are quite often, so you should really look at the musculoskeletal system, and also not so rare are tumors, metastases in the pancreas. So while these are hypovascular, this is hypovascular because it also has been already treated with anti-angiogenic therapy. So this brings us to therapy options and implications. First, I want to talk about nephrectomy and its alternatives, and then about anti-angiogenic therapy. So a long time, radical nephrectomy has been the only treatment of choice. And this is, I haven't done it myself, but it's a rather easy surgery, low complication rate. You just take out the whole kidney, low recurrence rate, of course. But however, the GVAR is reduced by 50%, and this is one of the factors which shortens the survival compared to partial nephrectomy. So that partial nephrectomy, nephron-sparing nephrectomy, has been established over the last years. So the tumor is resected, and then after this, the kidney is clamped for like 10 to 30 minutes, and a patch is inserted in the surgery defect. So you might discuss, so this, we had this tumor before. Would you do a partial nephrectomy on this? This one is quite short, a small, exophytic, no relation to the sinus system, to the sinus. Let's see. What about this one? This one is strange, looks like a snowball. It might be 2 tumors or just one. So we can see infiltration of the upper calyx group. Would you perform partial nephrectomy on this? Probably not. You can actually quantify the complexity of a renal tumor by using nephrometry scores. So there are a couple of scores. There is the Padua score, which is named after the city of Padua, and the renal score, which is an acronym for radius, the growth, the relation to the renal sinus, the localization of the tumors. They're principally quite similar, and the more points you accumulate, the more complex the tumor is. There's another score, or another index, the C-index, which is based on the findings of Pythagoras, which defines the centrality of the tumor. And the more central the tumor is, the more complicated the tumor is. So I would just like to demonstrate how to use this, because you don't have it in your head, but I think you don't have also to provide the urologist with a nephrometry score, but if you know what plays a role in the nephrometry, you can make your reports better. And this is what the urologist wants to know. So about this small tumor, so there's actually a website where you can click on it. So radius, smaller than 4 centimeters, exophytic. Has got no relation to the sinus. And if you look, where is the tumor localized, it seems to cross the polar line. So when we click here, so this is not, so if you click here, we then get our score, 5 points. So this is not very complex tumor. Regarding the other one, this one was 7.2 centimeters. Great parts of it are endophytic. It infiltrates the system, collecting system, and it crosses the polar line. And we get a score of, let me see, 11, which renders it a complex lesion. So this is all online, and this is quite fast and quite convenient. I like it very much. So what is the significance of the nephrometry score? Urologists can predict how long the operation time is going to be, and the more complex, the longer the operation time is. the amount of blood loss. The longer, the more complex lesion, the longer the ischemia time. And if you got a non-complex lesion, conversion to nephrectomy and overall complications are very low. Regarding complications after a partial nephrectomy, so the most common complication after partial nephrectomies are AV fistulas and pseudoaneurysms, most commonly in laparoscopic partial nephrectomy, and from personal experience, most common in robotic-assisted partial nephrectomy. Further complications can be pancreatic injury and urinoma. And with the rising number of partial nephrectomy, we see them, those complications even more often. So this is a patient after partial nephrectomy. We see swelling of the kidney, and we can see the surgery defect in this pseudoaneurysm. This patient was then underwent angiography. Here we can nicely see the pseudoaneurysm, and this is after superselective coil embolization. Superselective coil embolization is the therapy option of these tumors, and the loss of function is minimal if you do the procedure right and if you don't coil the big branches, if you go in super selectively. An alternative to partial nephrectomy may be ablative therapy, RFA or cryotherapy, which can be performed intraoperatively, which I think doesn't make much sense because if you're already operating, you can take out the tumor as well, but you can also do it percutaneously. The recurrence rate differs from side to side. Literature says 5 to 13%. And the common sense along the urologists is that it should be reserved for patients which are not eligible for surgery. And it should be reserved, or at best results are in small tumors, especially 10-1A. So this is a T1A, and these are smaller than 4 centimeters. And I think there's also a role for patients with unclear histology where you don't really know if is this malignant or benign. You might just do RFA and then get a biopsy, and just depending on it, you might just determine your further staging protocol. So our typical bleeding, a typical complication would be bleeding, which increases with tumor size, and in one work it was 33% in T2 tumors. And this is one RFA procedure performed in our institution. Ablative therapy can be assessed just visually. Sometimes it might be difficult to differentiate between post-operative changes or post-therapy changes and recurrence. You can do CT perfusion. Here after RFA we don't see any perfusion anymore, and here we see a recurrent tumor which is perfused after RFA. However, if the patient has got metastasis, then you would switch to other therapies. So the traditional therapy of malignancies was cytostatics and radiation, which destroyed the tumor cells. We had a change in tumor diameter, and we could assess them with RECIST. New therapy approaches are anti-angiogenic therapy, which disrupt the vascularity of the tumors. The tumor size stays the same. However, we've got a significant change in tumor attenuation, which is related to the tumor perfusion. So here we have got a hepatic RCC metastasis, baseline after 6 weeks of TKI therapy. We can see tumor is the same. RECIST would say stable disease, but we can nicely see the central necrosis, an unperfused part. So as I said, RECIST modified CHOI failed to predict progression-free survival in mTOR-treated RCC. So we're looking for new criteria for response. One might be the MAS criteria, which is based on RECIST, but it also takes into account a newly favorable response, newly occurred central necrosis. And if this necrosis goes away, this would be unfavorable response. And these MAS criteria were better able to distinguish between unfavorable and favorable, indeterminate and favorable response compared to RECIST. But however, this is not, so this is just a visual impression, and sometimes we might want to get quantitative data. So tumor perfusion, assessment of tumor perfusion might be interesting, which is actually an old story. So this is an image from the late 70s where we could see perfusion imaging of a brain tumor. And nowadays we can cover a whole volume. I've shown this image before, and we can just see that we can assess the tumor perfusion, and from this we can calculate perfusion and permeability. There's been nice correlation to histology and mean vessel density by Reiner et al., and we could see a good correlation between the blood flow and the mean vessel density and also a good correlation between the functional parameters and necrosis. Tumor response to anti-angiogenic therapy can be assessed very fast. So this is a CT perfusion case where we can see diminished blood flow and permeability already after a week. And this is the control after 3 months, where we've got a further reduction of perfusion permeability. And DC MRI shows almost the same. Here, tumor RCC metastasis in the pelvis, which is a little bit smaller after 3 months. In DC MRI, we see a significantly reduced plasma flow compared to the baseline. Diffusion-weighted imaging might be similar or show similar results. We got increasing necrosis and decreasing cell density and rising ADC after anti-angiogenic therapy. Early changes can be seen in diffusion-weighted imaging already after 3 days. However, one must be careful because this can also be related to cell swelling, and the early changes after 3 days did not correlate with the outcome. Early changes can also be seen in DC MRI. Also, after 3 to 10 days, we can see a decrease in the functional parameters. However, interestingly, the decrease itself does not correlate with the progression-free survival or the RECIST response, but interestingly, the baseline values, they do respond with the survival rate. So in these two studies, we could see that patients with a high baseline permeability had a better response against anti-angiogenic drugs, which is sound logical because a good perfused tumor will probably better respond if you destroy its vascularity. So in the last 2 minutes, I just want to talk about one common side effect of this therapy, tyrosine kinase inhibitors, and especially mTOR inhibitors. And this is pneumonitis, drug-induced pneumonitis, which is seen in 8 to 14% of the patients, depending on the study. There's direct damage of pneumocytes or the endothelium, and principally, if you want to diagnose drug-induced pneumonitis, you would have to rule out other differential diagnoses, and there's no specific pattern. There might be dense opacities or ground glass. In the end, you would have to do lung biopsy, and if the patient is symptomatic, you would have to withdraw the drug and administer a different second-line anti-angiogenic therapy. So these are just some examples. We've got small nodules and a halo. This one is invasive aspergillosis. This one looks almost the same. This one was drug-induced pneumonitis. This one is mycoplasma pneumonia with peribronchovascular nodular opacities. Same image, mTOR-induced pneumonitis. And this one looks like tuberculosis, big caverns, fuzzy boundaries, and this one looks almost the same. And finally, this one looks like lung cancer with the solid mass, speculated mass. This one looks almost the same. This was also mTOR-induced pneumonitis. So these are true cases, and we here ruled out any other differential diagnosis, and at the end, we stayed with mTOR-induced pneumonitis. So it's impossible. So it's very important that if you got a patient who's got metastasized RCC and has got strange changes in the lung, you should really think that there might also be pneumonitis, but you would have to rule out other differential diagnoses. And you should ask the urologist on which anti-angiogenic therapy are they under. Especially mTOR is important. So this is my almost last slide. What about how to time your follow-up? Patients with metastasis, you would follow up every 3 months. Usually they are in studies anyway. T1 patients, you would follow up once a year. T2, T3 patients, you would examine half yearly, and then on a yearly basis after 3 years. So these are the American guidelines. So in the end, I would like to summarize. CT is the mainstay of RCC staging. This is usually the only modality you need. The correct staging determines the prognosis and the survival of the patients. The local staging is important for therapeutic decision-making, partial nephrectomy, radical nephrectomy, anti-angiogenic therapy. The new treatments can cause new complications like bleeding or pneumonitis. And assessments of anti-angiogenic therapy, I think there's going to be a whole session about this, it's not clear how to do it best. Functional imaging might be one way to do it. Thank you very much for your attention.